Wow, have you ever heard of an infection that spreads so fast? Talk about a medical mystery that just takes off.
Oh, yeah. I know what I mean.
We're going to dive into something pretty intense today.
Yeah.
Necrotizing fasciitis.
Yeah, scary stuff.
You might know it as that flesh-eating disease. Thankfully, it's rare,
Yeah.
but it can be really bad.
For sure.
And when it hits,
You got to be ready.
it needs attention right away, doesn't
Oh,
it?
absolutely.
So today, as medical microbiologists listening to this, we're going to explore this whole condition, all right?
Let's do it.
And we're going to be using a really cool guide, the World Health Organization's AWARE book
Yeah.
on antibiotics, access, watch, reserve, that one.
Hey, I've got that one.
So you're going to be totally set after this deep dive. You're going to know all the key stuff about necrotizing fasciitis.
Sounds good.
So, ready to get started?
Definitely. Let's go.
All right. It's a condition that really makes you think on your feet, doesn't it?
Oh, yeah. You got to make decisions fast.
You got to be decisive.
Yeah.
And anyone in medicine, I think, just really needs to understand all the little detail.
All the nuance.
The nuances of necrotizing fasciitis, yeah.
Absolutely.
So I guess first things first, we're going to define it right.
Sure.
What exactly are we talking about here?
Yeah.
Because honestly, it sounds kind of terrifying. Flesh-eating disease.
I mean, yeah, the term flesh-eating, it sounds a bit dramatic, right?
Yeah.
It gets the point across, that's for sure.
Yeah.
This is serious stuff. So necrotizing fasciitis, it's a bacterial infection, and it moves fast.
Fast, yeah.
It really targets the fascia.
A fascia, okay.
Which, it's the connective tissue around your muscles and organs. It's like the wrapping.
Oh, okay.
And this infection, it can actually cause the tissue to die.
Die.
Yeah, we call that necrosis. And the bacteria just keep spreading.
So it's not like actually eating the flesh.
Not literally, no.
But it's making it die.
Exactly. It's causing it to die off.
Okay, that makes a little more sense.
And to make things even more, complicated.
Yeah.
There are different ways we classify this thing.
Okay.
Like, we got to figure out if it's monomicrobial,
Monomicrobial.
meaning it's caused by just one type of bacteria,
Okay, one bad guy.
or if it's polymicrobial.
Okay, polymicrobial.
That means it's a whole mix of bacteria, or a real party.
Oh no, a party in your fascia.
Not the kind you want.
Yeah, not a good party.
And then we also look at the location, right?
Yeah.
Where is this thing happening?
Oh, that makes sense.
Because it can be, the legs, the arms, the torso, the head and neck.
Oh, wow.
Or even the perineum.
The perineum.
Yeah. And that's when things get really serious. We call that Fournier gangrene.
Oh, I've heard of that.
Yeah, it's a tough one.
Fournier gangrene, that sounds rough.
It is.
Okay, so location matters for sure. And Fournier gangrene, we'll have to unpack that a little bit more later.
Definitely.
But first, I guess let's back up for a sec.
Oh.
If you're a medical microbiologist like yourself, what are you looking for, in a patient? How does this thing present?
Good question. The real telltale sign, the hallmark of necrotizing fasciitis, is pain.
Pain.
Intense pain. And here's the thing.
Yeah.
It doesn't match what you see on the skin.
What do you mean?
Like, imagine someone comes in with what looks like, just a little skin irritation.
Okay.
But they're in absolute agony.
Oh, wow.
That is a huge, huge red flag.
So the pain is way out of proportion.
Way out of proportion to what you're seeing.
Okay, so pain is a big clue,
Absolutely.
even if you don't see much on the skin.
Yeah.
What other symptoms should make you think, maybe this is necrotizing fasciitis?
Well, along with that intense pain,
Yeah.
you might see the usual signs of an infection, right? Redness, warmth, swelling in the area.
Yeah, the classic signs.
Classics.
Yeah.
But as the infection keeps going, you'll start to see more serious stuff.
Well, like what?
Like the skin might change color, you might see blisters, or even areas of black dead tissue. That's the necrosis we talked about.
Oh, so it can get really bad really fast.
It can. That's one of the things that makes it so dangerous.
So you got to catch it early.
Absolutely. Early diagnosis is key. Oh, and one more thing.
Yeah.
Things can look a little different in kids.
Oh, interesting. How so?
Well, for example, in infants,
Yeah.
the infection often shows up on the torso.
Okay, so the torso in infants.
But in older kids, it's more common in the limbs and face.
So different presentations depending on age.
Got it.
So let's say a medical microbiologist, they're looking at a patient and they're starting to suspect necrotizing fasciitis. What kind of lab tests do they need to do, to confirm that it actually is that and to figure out the best way to treat it?
Okay, so lab tests are absolutely crucial here.
Essential, yeah.
First and foremost, blood cultures.
Blood cultures, okay.
And ideally, you want to get those before you start any antibiotics.
Oh, so before any treatment.
Before any treatment. This helps us pinpoint exactly what bacteria is causing the infection.
Makes sense.
Then during surgery, when they're doing what we call surgical debridement,
Surgical debridement.
which means removing the infected tissue,
Okay.
we take deep tissue samples.
Ah, I see. So we're talking blood cultures and deep tissue samples.
You got it.
And both of those are to figure out which bacteria is the culprit.
Exactly. And those deep tissue samples, those are really important for the microbiology lab.
Oh, right.
They use those to do microscopy and culture the bacteria.
Right.
That way, we can tell if it's just one type of bacteria causing the problem or if it's a whole bunch of them.
Monomicrobial or polymicrobial.
Exactly.
Okay, makes sense. So aside from figuring out which bacteria we're dealing with, are there any other lab tests that are helpful?
Definitely. We need to know how severe the infection is, and we need to get a good picture of the patient's overall health.
Yeah, the whole picture.
Exactly. So we'll check their white blood cell count, their C-reactive protein levels, their procalcitonin levels. Those are all markers of inflammation.
Inflammation, okay.
Then we'll look at their complete blood count, creatinine, electrolytes, glucose, hemoglobin, all that good stuff.
Wow, so it's really about getting a complete picture of what's going on.
Exactly. Both with the infection itself and the patient's overall health.
Okay, so lab tests, they're super important.
Absolutely.
Now, what about imaging? Does that play a role in diagnosing necrotizing fasciitis?
It can, but we have to be very careful. Imaging should never, and I repeat, never delay surgical intervention.
Oh, wow. Okay.
Things can move very quickly with this infection.
So surgery takes priority.
Always. We might use ultrasound or a CT scan to help visualize how far the infection has spread.
Okay.
But remember, the most important thing is getting in there quickly and removing that infected tissue.
So don't wait for the imaging results to come back before you act.
Exactly. Delaying surgery just to get an image, that could allow the infection to spread further and make things much, much worse.
Oh, that makes sense. All right, so let's talk about treatment. What do you actually do for necrotizing fasciitis?
Well, as I just mentioned, surgery is the cornerstone of treatment. The first thing we do is get that infected tissue out as fast as possible.
That surgical debridement.
Exactly. That's how we stop the infection from spreading.
Okay, and what about antibiotics? Do those come into play at all?
Antibiotics are absolutely crucial too.
Okay.
But they work hand in hand with surgery. They're not a substitute for it.
So it's not one or the other?
Nope. It's both.
Okay.
Antibiotics, they help kill the bacteria and control the infection, but they work best when we've also surgically removed the infected tissue.
So it's a two-pronged attack.
Exactly. Hit it from both sides.
Surgery to get rid of the infection and antibiotics to kill the bacteria.
You got it. Now, when it comes to antibiotics, we usually start with what we call a broad spectrum approach.
Broad spectrum, what does that mean?
That means we use antibiotics that can target a wide range of different bacteria.
Okay.
Because in the beginning, we don't know exactly what bacteria we're dealing with. We have to wait for those culture results to come back.
So you cast a wide net.
Exactly. We cover as many bases as possible until we know exactly who the enemy is.
That's a good strategy. So what are some of the antibiotics you typically use in those initial stages?
For adults, the go-to combo is piperacillin plus tazobactam and clindamycin.
Piperacillin plus tazobactam and clindamycin. Okay.
We give 4 grams of piperacillin plus tazobactam every 6 hours intravenously and 900 milligrams of clindamycin every 8 hours, also intravenously.
Okay, so IV for both of those.
Yep. And if we think MRSA might be involved,
MRSA.
methicillin-resistant Staphylococcus aureus, that's a tough one.
Oh, yeah.
We add vancomycin to the mix.
Vancomycin, okay.
We give that at a dose of 15 to 20 milligrams per kilogram every 12 hours.
Wow, so you really have to keep track of all those dosages and timings.
It's important to get it right.
Absolutely.
Now, if we don't think it's Streptococcus pyogenes, also known as Group A strep,
Okay, group A strep.
we have another option. We can use ceftriaxone and metronidazole.
Ceftriaxone and metronidazole.
Ceftriaxone at 2 grams once a day intravenously, and metronidazole at 500 milligrams every 8 hours intravenously. And again, if we're worried about MRSA, we add vancomycin.
So two main options, depending on the suspected bacteria.
Exactly.
But how long does this, intense antibiotic treatment typically last?
Well, it depends.
On what?
It depends on the patient and how they're responding.
Okay.
But usually we aim for somewhere between 2 and 3 weeks.
2 to 3 weeks, wow.
And of course, we adjust the antibiotics based on those culture results we talked about and how the patient is doing clinically.
So it's not like a one-size-fits-all approach?
Nope.
You're constantly monitoring and making changes as needed.
Exactly. We might switch to a narrower spectrum antibiotic once we have the culture results or if the patient shows signs of improvement. And sometimes we can even transition to oral antibiotics. The key is to tailor the treatment to each individual patient.
So it's all about personalized medicine, even in these really urgent, life-threatening situations.
Absolutely.
Okay, that makes sense. Now let's switch gears a bit and talk about the how and why behind this infection.
Sure.
How do these bacteria actually get into the fascia and cause all this damage?
That's a great question. There are a couple of ways bacteria can invade the fascia.
Okay.
One way is through a break in the skin, like a cut, a wound, a bite, even an injection site.
So any kind of opening in the skin.
Exactly. Any way for the bacteria to get past that protective barrier.
Makes sense.
The other way is through a breach in the mucosal barrier.
The mucosal barrier.
Yeah, like in the intestines or the oropharynx.
Okay, so it could be an outside invasion or it could be like an inside job.
You got it.
With bacteria that are already in the body causing the trouble.
Exactly. We call those exogenous, meaning from the environment, and endogenous, meaning from within the body.
Fascinating. So once these bacteria have managed to sneak into the fascia, what do they do to cause so much damage?
Well, they trigger a whole chain reaction that leads to tissue damage, necrosis, and a buildup of inflammatory fluid.
So it's not just the bacteria themselves.
Nope.
It's also the body's own inflammatory response that's contributing to the problem.
Exactly. It's like the body is fighting back, but in doing so, it's actually making things worse.
Wow, that's a tough situation. So let's zoom out a bit now and look at the bigger picture, the epidemiology of necrotizing fasciitis.
Okay.
We know it's a rare disease,
Thankfully.
Yeah. But who's most at risk? Are there any specific risk factors that we should be aware of?
The risk factors depend on the type of necrotizing fasciitis we're talking about.
Okay, so different types, different risks.
Right. Polymicrobial necrotizing fasciitis, the kind with multiple bacteria. That tends to be more common in older adults.
Older adults, okay.
And people with underlying health conditions.
Mm-hmm.
Things like diabetes, vascular disease, or a weakened immune system.
So people who are already a little bit more vulnerable.
Exactly. People who have had recent trauma or surgery are also at higher risk. Oh, and people who inject drugs.
So those are the folks who are more likely to get the polymicrobial type. What about monomicrobial? Who usually gets that?
That one's a bit more of a wild card.
How so?
It can happen to anyone, really, any age, even people who are otherwise healthy.
So it's not always tied to pre-existing conditions or vulnerability?
Nope. And it's the most common form in children.
Interesting.
And we also have to be on the lookout for another serious complication that can arise, toxic shock syndrome.
Oh, right. Toxic shock syndrome. That's a scary one. How is that connected to necrotizing fasciitis?
Well, toxic shock syndrome can happen as a complication of necrotizing fasciitis, usually when it's caused by certain types of bacteria like Streptococcus pyogenes or Staphylococcus aureus. These bacteria, they can produce toxins that trigger a severe reaction throughout the body.
So it's like a double whammy.
Yeah, you could say that.
You've got the tissue damage from the infection itself, and then on top of that, you've got this whole body reaction.
Exactly. It really makes you realize how serious this infection can be. All right, to wrap up this part of our deep dive, let's talk about the bacteria that are most often involved in cases of necrotizing fasciitis.
Okay, so like the usual suspects.
Exactly.
Yeah.
The bacterial bad guys. And remember, we have those two main types, monomicrobial and polymicrobial.
Right, solo actors and group projects.
Something like that. So starting with the monomicrobial infections, the one that shows up most often is Streptococcus pyogenes. You might know it as Group A strep.
Group A strep, always causing trouble.
It sure is. Other potential culprits in this category are Streptococcus agalactiae, or Group B strep, and Streptococcus dysgalaxia. That one's more common in elderly and chronically ill patients.
So those are the strep superstars of monomicrobial necrotizing fasciitis. Are there any other bacterial baddies we should be on the lookout for?
Staphylococcus aureus can also cause monomicrobial necrotizing fasciitis including MRSA. It's not as common as the strep infections, though.
Okay.
And then we have a couple of bacteria that are linked to specific environmental exposures. Aeromonas hydrophila likes to hang out in fresh water, so we sometimes see infections after people swim in lakes or rivers.
So if you're a freshwater swimmer, watch out.
Exactly. And then there's Vibrio vulnificus. That one's found in seawater, so exposure to contaminated seafood or seawater can lead to infection.
So the environment plays a role in some cases.
Interesting. Now, what about the more complex polymicrobial infections? Which bacteria are usually involved in those?
Those often involve a mix of bacteria, including anaerobic bacteria like Bacteroid species, Clostridium perfringens, and Peptostreptococcus species.
Anaerobic bacteria, those are the ones that thrive in environments without oxygen, right?
That's right.
So why are they found in necrotizing fasciitis? Well, when you have tissue death, those areas can become oxygen deprived.
Oh, I see.
That creates the perfect environment for anaerobic bacteria to grow and multiply.
Makes sense. So in addition to those anaerobic bacteria, what else are we likely to see in polymicrobial necrotizing fasciitis?
We often see Enterobacterales, Pseudomonas species, various Streptococcus species, and of course Staphylococcus aureus, including MRSA. It's really this combination of different bacteria that makes these polymicrobial infections so difficult to treat.
Okay, we've covered a lot of ground already.
We have.
We've talked about the definition of necrotizing fasciitis, the clinical presentation, the lab tests, imaging, and treatment approaches.
And even the microbiology behind it all.
Exactly. We've even delved into the world of the bacteria that are most commonly responsible for this condition. But before we move on,
Yeah.
I think it's time to put your knowledge to the test. Ready for some exam-style questions?
Hit me with them.
Okay, let's see what you've learned. First question coming at you. What is the hallmark clinical presentation of necrotizing fasciitis? Think back, this is like a classic.
All right, yeah, good one to start with. It's that severe pain, but it's like way more pain than what you'd expect from just looking at their skin, you know?
Right, the skin might look okay?
Yeah, early on it might not look so bad, but the patient, they're going to be in a lot of pain, like really bad pain.
Yeah, and that's the key.
Yeah, that mismatch, the skin looking fine, but the pain being so bad.
That's a red flag.
Huge red flag. It tells you there's something worse going on underneath, you know?
Deeper, something's brewing.
Yeah.
All right, excellent, you got it. That pain, that's the key. Can't ignore that.
Definitely not.
Question number 2. Which imaging modality is preferred for diagnosing necrotizing fasciitis, and why? Think carefully about this one.
Yeah, this is where we have to remember that with necrotizing fasciitis, time is like everything.
Time is of the essence.
Yeah, so imaging like ultrasound and CT scans, they can be helpful to see how bad it is and where it's spread.
Visualize it.
Yeah, but you should never wait for those results before doing surgery.
Oh, so surgery first, imaging later.
Exactly. With necrotizing fasciitis, surgery is how you diagnose and how you treat it at the same time.
Oh, 2 birds with 1 stone.
Yeah, we got to get in there and see what's going on and get that infected tissue out as fast as possible.
So no delaying surgery just to get a picture, huh?
No way. Delaying surgery could really make things much worse for the patient.
All right, good to know. Moving on to question number 3. What are those first-line empiric antibiotic treatments for adults when you suspect necrotizing fasciitis? Let's see if you remember those antibiotic regimens.
Okay, so for adults, you have a couple of options, those first-line empiric treatments. You can go with piperacillin plus tazobactam and clindamycin.
Okay, the dynamic duo.
You would give 4 grams of piperacillin plus tazobactam every 6 hours intravenously, and then 900 milligrams of clindamycin every 8 hours, also IV.
All right, IV for both.
Yeah. The other option, if you don't think it's Streptococcus pyogenes, that group A strep, you can use ceftriaxone and metronidazole.
Right, ceftriaxone and metronidazole.
2 grams of ceftriaxone intravenously once a day, and then 500 milligrams of metronidazole intravenously every 8 hours. And, if you suspect MRSA, got to add vancomycin to either regimen.
Okay, so those are 2 main options. Perfect, you nailed those antibiotic regimens. Now let's see how you do with pediatric presentations. Question number 4. Describe the key differences in the clinical presentation of necrotizing fasciitis in kids, compared to adults. There are some important things to remember.
Right. So a lot of the signs and symptoms are the same, but there are some key differences with kids. The location of the infection can be different. Like in infants, it's usually the torso that gets infected.
Torso, for instance, got it.
But in older kids, it's usually the limbs and the face that are more commonly affected. And kids with necrotizing fasciitis, they might have a fever more often than adults.
Okay, fever in kids. Good to know. You're on a roll. All right, ready for the final question. This is all about the microbiology.
Bring it on. Let's see what you've got.
What are the most common pathogens associated with monomicrobial necrotizing fasciitis? Those solo actors.
Okay, let me think. So for monomicrobial necrotizing fasciitis, the most common ones are Streptococcus pyogenes, which is also called Group A strep, Streptococcus agalactiae, which is Group B strep, and then Streptococcus dysgalactiae, which is seen more often in elderly patients and those who are chronically ill. Those are the main ones to remember.
That's a wrap. 5 for 5, you aced all the questions. You've been paying attention, that's for sure. You really know your stuff about necrotizing fasciitis.
Well, it's a condition you can't take lightly, that's for sure.
Absolutely not.
And this information, it could make a real difference. It could save lives.
Yeah.
It's a good reminder that even with everything we know in medicine, these infections can still be really dangerous if we don't catch them early and treat them the right way.
Early recognition, quick surgery, and the right antibiotics.
That's the key. It's
Yeah.
a big challenge for sure.
Yeah.
Treating these infections is already a big deal, right? We've got to get in there, remove the infected tissue with surgery, hit them with antibiotics, the whole 9 yards.
Aggressive approach.
Yeah, but the problem is, as resistance to antibiotics gets worse and worse,
Yeah.
it's like our weapons are getting weaker.
So what happens then? I mean, what if those antibiotics we're using, they just don't work anymore? What happens to those patients?
It's not good. I mean, treatment might fail.
Yeah.
People might stay in the hospital longer.
Larger stays. Yeah.
And the worst part, more people might die.
That's the scary part.
Yeah, we're basically in a race against time here. We got to develop new antibiotics that can keep up with these evolving bacteria.
So it's not just about knowing what to do now. It's about looking ahead, right?
Absolutely.
Anticipating those future challenges. What are some of the things, like in research, what's giving you hope?
Well, there's some really cool stuff happening. Phage therapy, for example.
Phage therapy, what's that?
It's like using viruses, these things called bacteriophages, to target and kill bacteria.
Oh, so it's like fighting fire with fire.
Yeah, kind of. It's a very specific approach. And the best part is these phages, they can evolve along with the bacteria.
So they stay one step ahead.
Exactly. They're always adapting. So it's a really promising way to fight antibiotic resistance.
So instead of those broad spectrum antibiotics that can wipe out everything,
Good and bad bacteria.
yeah, we could use these specialized viruses to go after the specific bacteria causing the infection. That's amazing.
It is. And because they're so specific, phages are less likely to cause even more resistance down the line.
That's a huge advantage. What else? Any other promising research avenues?
Immunotherapy is another big one.
Immunotherapy.
Yeah, the idea is to help the body's own immune system fight off the infection better.
Oh, so it's like boosting the body's natural defenses.
Exactly. We could use monoclonal antibodies or immune checkpoint inhibitors, things like that.
So we're not just attacking the bacteria directly, we're helping the body fight back.
Right.
I like that approach.
And of course, we can't forget about antimicrobial stewardship,
Antimicrobial stewardship.
which is just a fancy way of saying we got to use antibiotics responsibly. The more we use them, the faster resistance develops.
That's about to be careful.
Yeah, we have to be mindful about how we use antibiotics, both in hospitals and out in the community. It's everyone's responsibility.
Absolutely. We're all in this together. Well, we've covered a lot today.
We have.
From the scary parts of necrotizing fasciitis to how to prevent it.
And everything in between.
But before we wrap up, I want to leave you with something to think about. With this whole problem of antibiotic resistance,
Yeah.
what challenges do you see in treating necrotizing fasciitis in the future?
It's a tough question. As resistance keeps growing, it's going to make treating these infections even harder, especially the polymicrobial ones.
Yeah, those are already tough.
They really are. And they often involve bacteria that are already resistant to multiple drugs.
So what can we do?
Well, we have to keep pushing for new drug development. That's number one.
New antibiotics.
Yep. And we have to keep exploring new treatment strategies like those we talked about earlier. Phage therapy, immunotherapy, those kinds of things.
So staying ahead of the game.
Exactly. And we also have to educate everyone about antibiotic resistance and why it's so important to use these drugs responsibly.
Right, so it's a multifaceted approach. Research, new treatments, education.
It really is. And medical microbiologists, they play a huge role in all of this.
How so?
Well, they're the ones who identify the bacteria, figure out the resistance patterns, and help guide treatment decisions. They're crucial in making sure patients get the best possible care.
It's a challenging field, for sure.
Yeah.
But it's also incredibly rewarding, right?
Oh, absolutely. To know that you're making a real difference in the lives of people who are facing these serious, potentially life-threatening infections.
That's gotta feel good.
It does. It's a privilege to be able to use our knowledge and skills to help people in need.
Well, I have to say, this deep dive into necrotizing fasciitis has been amazing.
It's been a journey.
It really has. It shows you how quickly things can go wrong, how delicate that balance is between our bodies and all those microbes out there.
That's for sure. We have to respect that balance.
We do. And we have to stay informed, keep learning, and advocate for responsible practices in healthcare. Thanks for guiding us through this. I feel like I've learned so much.
It's been my pleasure. Remember, knowledge is power. And the more we know about these infectious diseases, the better equipped we are to fight them.
Couldn't have said it better myself. So until next time, stay curious, stay informed, and stay healthy.